Good evening, dear colleagues. I'd like to thank Dr. Iakovou for the kind invitation. I will be presenting today a case of an 86-year-old female patient with a severe degenerative mitral regurgitation successfully treated with TEER. The patient was admitted to our hospital's emergency department with dyspnea, NUHA 3, no prior history of cardiovascular disease, and her only comorbidity was a COPD Gold Stage 2. The ECG showed a normal sinus rhythm with pre-terminal T-wave inversion of the inferior leads. The chest X-ray showed cardiomegaly with minimal pleural infusion and no pulmonary infiltration. And the transthoracic echo showed mildly reduced left ventricular ejection fraction with signs of inferior hypokinesia and a severe eccentric mitral regurgitation. The following day, we performed a coronary angiography with no evidence of coronary artery disease. In order to better assess the pathology of the valve and to understand the mechanism of the regurgitation, we performed an TE, and we really confirmed that it is a severe eccentric mitral regurgitation with a three-dimensional regurgitant orifice area of 1.4 square centimeters with pulmonary vein systolic flow reversal. The underlying pathology was also complex, involving both the anterior and the posterior leaflet of the valve. And specifically, there was an anterior prolapse involving both A2 and A3 scallop with flail leaflet of A2 scallop and a posterior prolapse of P2. The flail gap was 4 millimeters and the flail width was also 4 millimeters. The mitral valve area was measured at 3.9 square centimeters with a mean pressure gradient of 2 millimeters of mercury. After completing the diagnostic workup, we calculated the Euroscore 2, which was 6%, indicating a moderate perioperative risk, and we presented the case to our heart team meeting. Our surgeons were willing and expressed confidence to perform a minimally invasive repair, surgical repair of the valve, but the patient and the family declined any surgical intervention. So we had to evaluate the patient for transcatheter edge-to-edge repair. According to the latest consensus documents about suitability of anatomical suitability on TEER, our pathology here falls under the category of complex but still suitable for TEER. So we decided to proceed and plan our strategy. In every case, in planning device placement, we always aim to respect the pathology, the native anatomical commissures in order to avoid tension across segments after deployment of our devices. Given the anatomical complexity and the extensive regurgitant orifice area, we opted upfront for a two-device strategy with start medial. And that would be our initial plan, respecting the anatomical commissures of the valve. But we also had a concern, and that concern was that if we created with our two devices a manner of V-shaped configuration, we would also leave a central gap between the devices, possibly resulting in a significant residual regurgitation after deployment. So after internal discussion within the team, we decided to modify our plan and position our medial device slightly more clockwise than usual, thus allowing the second device being placed parallel and really close to the first one and minimize the gap. And that was the plan we proceeded with. So that's the first device, the placement of the first device medially. On the right top corner, you can see that it's slightly more clockwise placed. I have to mention that the aorta is at 6 o'clock. So we use the unhappy smile for imaging. And the deployment of the device was not very easy. Our first attempt was not satisfactory because, as you can see, the grasping of the pretty long anterior leaflet was not, we didn't get enough tissue of the leaflet, so we had residual jet coming through the device. So we released both leaflets and we optimized it, and we managed to grasp enough tissue of both leaflets. And that's the result after closing our device and before releasing it. So we have a nice leaflet insertion. On the right, you can see we have a stable tissue bridge and no jet coming medial to the device. We practically eliminated the medial jet. So we have space, and our gradient of 1.2 millimeters of mercury allows us to place a second device. So we release the first device, and we place our second device, which was pretty easy because through the first device, both leaflets were better aligned to each other. So with the first attempt, we could grasp both leaflets, and that's our final result after releasing the second device as well. We have a nice tissue bridge. Both devices are placed really close and parallel to each other. And overall, we could reduce the severe regurgitation to only mild. Our mean pressure gradient was 2.4 millimeters of mercury, pulmonary vein signal normalized, and at the 3-month follow-up, the transthoracic echocardiography showed a stable device positioning and still a mild regurgitation. Thank you very much for your attention.
So this was very, very difficult case, and excellent presentation. Congratulations. It's very interesting. First, we are distracted a little bit, maybe because the aorta is in 6 o'clock.
Yeah, our imager likes more the unhappy smile on the aorta. So we have 3 to 1.
This is a German thing, maybe.
It's your thing.
Okay. So, and the other, you placed the first clip more medially and more clockwise, let's say.
Yes.
But at the same time, did you respect perpendicularity, or it's
not totally?
Not totally.
So
this is something that we always try to do. I don't know. So Vangelis, so if we have been doing this case, so maybe.
No, excellent case. Congratulations. I think the end justifies the means. It was excellent. Sometimes you don't respect the line of coaptation. And like in this case, the main thing is to not have the valve distorted at the end, to not have an eccentric jet at the end. You didn't have that, so excellent case and excellent strategy.
Thank you very much.
Dr. Katsianos, do you have a comment on that? How would Hygeia Hospital approach this case?
Congratulations, or I would say herzlichen Glückwunsch. Generally, a great result. Generally, we try to, we have learned that the outcome is not guaranteed better with a second or a third device. We try to place one device in the middle, trying the different clockings, and then we, of course, if the outcome is not satisfactory, then we proceed with the second device. But it was a great outcome.
Thank you. As I said, the regurgitant orifice area was pretty extensive, 1.4, so we thought even with one device we could practically split the jet in half, not really reducing the regurgitation in a satisfactory level.
Excellent. So, Nico, do you have a comment?
Yes, so excellent case, very challenging anatomy, very severe MR. Yeah, I agree. Usually, it's hard to predict sometimes how what you're gonna end up with after the first clip. So sometimes, you may end up with mild MR in some way that it will be satisfactory for this 86-year-old patient. But the two clips work perfectly in this case, and I agree. Like, usually, as we get a little closer to the commissures, like more medial, more lateral, sometimes not being completely perpendicular, to our plane and being more like canted like this with eclipse, maybe retains the physiological coaptation more of the valve. So that was a very nice, a very nice technique, a very nice orientation there for the eclipse.
Thank you.
Good. So, excellent. Thank you.